Welcome back to the deep dive. Today we're tackling a really heavy topic, diving deep into schizophrenia and other psychotic disorders.
That's right.
We're using Kaplan Sadock's 11th edition as our guide here. The aim is to quickly pull out the key clinical ideas, the neurobiology, and how diagnosis and recovery look today.
Exactly. And for you listening, this is about getting a solid college-level grasp without getting lost in, overly dense history or jargon. We really want to trace how our understanding evolved, moving from those older, sometimes rigid categories to the dimensional view we use now. And crucially, connecting that to what it means for people's lives.
Okay, because the history itself seems pretty complex, right? Just figuring out what you were looking at seems to have been a major challenge. So where do we even start with classifying these disorders? Who kicked things off?
Well, you really have to begin with Emil Kraepelin. He was working around the late 19th, early 20th century. His big contribution, really foundational, was using prognosis, the likely outcome, to split things up. He made two main groups.
The famous two buckets approach.
Pretty much. So on one side, you had dementia praecox. That's what we now call schizophrenia. He saw it as deteriorating, defined by this loss of the inner unity of intellect, emotion, and volition. The assumption was, well, a poor outcome.
And
that was manic depressive psychosis, which is closer to what we think of as affective psychosis or mood disorders now. The key assumption there was a non-deteriorating course. That difference in expected outcome was the core distinction.
So a bit of a pragmatic, maybe even harsh system. If you got better, it's one thing. If you didn't, it's the other. Did people try to refine that, look for more specific signs?
Oh, definitely. That leads us to Schneider. He tried to make diagnosis more reliable with his first-rank symptoms, or FRS.
Right, things like thought insertion, thought withdrawal.
Exactly. Those kinds of very specific, almost signature experiences, they were hugely influential, no doubt. But the problem was, some doctors started taking just one FRS as enough to diagnose schizophrenia. It became a bit too much of a shortcut.
Which we now know isn't quite right, as FRS can appear in other severe conditions too. But this subjectivity really comes into focus with that story about diagnostic differences across countries, right?
Oh, absolutely. This is such a critical piece of the history. The US-UK cross-national project back in the mid-20th century. It uncovered this massive disparity.
What did they find exactly?
They found that something like 60% of psychiatric admissions in New York State hospitals were getting diagnosed with schizophrenia.
60%? Wow.
Yeah, and that was roughly double the rate they were seeing in London hospitals at the same time.
That's incredible. So your diagnosis literally depended on where you lived.
Essentially, yes.
Yeah.
The U.S. criteria were just much broader, less strict. It wasn't until they brought in standardized diagnostic interviews in New York that the rates dropped dramatically and started matching London's.
A real wake-up call about reliability.
A huge one. That failure really pushed the field towards the explicit criteria-based systems we have now, like DSM-5-TR and ICD-11.
Okay, so let's talk about those modern criteria. The textbook mentions dropping the old subtypes of schizophrenia. What took their place?
Right, subtypes like paranoid, disorganized, catatonic.
Yeah.
They were dropped. They just weren't stable over time and didn't really predict treatment response or outcome very well. So now we use a dimensional approach. Instead of just saying yes or no to schizophrenia, clinicians quantify the severity of different symptom dimensions.
Like delusions, hallucinations.
Exactly. Delusions, hallucinations, negative symptoms, disorganized thinking, cognition, each rated on a scale, often 0 to 4. It captures the huge variation you see in the illness much better.
And what's the cardinal rule before you even assign that diagnosis?
Exclusion. Always exclusion first. You have to rule out that the symptoms are actually caused by something else, a substance, a medication side effect, or another medical or neurological condition. ICD-11 even calls these secondary psychotic syndromes, to make that clear.
Okay. And catatonia, you mentioned that shifted too.
Yes. Catatonia is now its own separate category. It can be linked or specified with schizophrenia, schizoaffective disorder, mood disorders, or even medical conditions. It's recognized as a distinct syndrome that cuts across diagnoses.
All right, let's dig into those symptom dimensions then. Starting with the positive symptoms, the ones that are maybe most obvious or dramatic, hallucinations and delusions.
Okay, so hallucinations are sensory perceptions without any actual external stimulus. Auditory ones, hearing voices, are the most common by far. The text says over 70% of people with schizophrenia internationally experience them. And interestingly, patients often sort of test the reality of these voices.
Trying to figure out where they're coming from.
Yeah, but their own inability to explain them away often ends up proving the reality of the voices to them, if that makes sense.
And delusions often follow from that, like an explanation for the voices.
Very often, yes. They can be interpretive. Delusions themselves, these fixed false beliefs, aren't unique to schizophrenia, of course. The text even mentions a German study where like a quarter of the general public reported having special powers or something.
Really?
Yeah. So the difference in psychosis isn't always the content of the delusion, but its frequency, how much it impacts life, the conviction, and how it fits into the overall pattern of illness. They often involve conspiracies or external control to make sense of those bizarre hallucinatory experiences.
Got it. Now, moving to negative symptoms, you said these are crucial for prognosis.
They really are, arguably the most critical for long-term functioning. These are deficits, like things that are missing from normal behavior. We're talking about avolition, lack of motivation, anhedonia, inability to feel pleasure, asociality, social withdrawal, affective blunting, reduced emotional expression, and allogioparvity of speech. These negative symptoms might actually be better at distinguishing schizophrenia from other psychoses, and they're the ones most strongly linked to how well someone does long-term.
Can we clarify avolition and anhedonia? They seem related.
They are, but there's a subtle difference. Avolition is more about the loss of drive or will, that inability to start or stick with goal-directed things.
Okay.
The book calls it the single biggest driver of disability tied to negative symptoms.
Okay.
Anhedonia is specifically about the reduced capacity for pleasure, finding things enjoyable. And that one tends to be perhaps the most persistent over time. Clinicians use scales like the BNSS or Canes to measure these carefully.
And the distinction between primary and secondary negative symptoms, why is that so important for treatment?
Oh, it's vital. Primary negative symptoms are thought to be part of the core illness itself, intrinsic. Secondary ones are caused by other factors, maybe side effects from medication making someone seem slowed down, or depression causing low motivation, or even someone withdrawing socially because they're paranoid.
Right.
The key difference is that secondary causes can often be treated or resolved. Adjust the meds, treat the depression, and the symptom might improve, often within about a year. Primary negative symptoms are much tougher to treat.
Okay, that makes sense. And before we move fully into the biology, let's touch on the disorganization dimension again, including catatonia. You mentioned a surprising fact about catatonia's prevalence.
Right. Disorganization covers things like formal thought disorder, jumbled speech, tangentiality, plus bizarre behavior and inappropriate affect. Catatonia falls under this umbrella too. It's a specific psychomotor disturbance. You need at least 3 signs out of 12, like stupor, waxy flexibility, mutism, excessive motor activity.
And the surprising part.
Yeah, the surprise is that catatonia is actually found more often in severe mood disorders, like bipolar disorder or depression with psychotic features, and in medical conditions like encephalopathies, than it is in schizophrenia itself.
Huh. Interesting.
Which really supports the DSM-5-TR decision to make it a specifier that can apply across different diagnoses rather than a subtype of schizophrenia.
All right, let's shift gears now from symptoms to the underlying biology. The textbook is very clear. Schizophrenia is a brain disease, and genetics play a huge role.
A massive role. Adoption and family studies point to heritability estimates around 81%. That's substantial. And specific genes implicated. Well, there's a convergence of findings pointing towards problems with synaptic function. Genes related to the dopamine D2 receptor, glutamate signaling, calcium channels that keep cropping up.
So genetics points to synapses. What about the brain structure? What does imaging like MRI show us?
Structural MRI findings have been pretty consistent over the years. The single most replicated finding in large lateral ventricles. That shows up in about 80% of studies.
Okay.
We also consistently see reduced volume in medial temporal lobe structures, particularly the hippocampus and amygdala. That's reported in roughly 74% of studies. And this fits with the disconnectivity idea that the wiring is off. Diffusion MRI, which looks at white matter tracks, confirms abnormalities, especially in pathways connecting frontal and temporal lobes, like the uncinate fasciculus and corpus callosum.
And the classic dopamine hypothesis, what does molecular imaging like PET tell us?
PT scans have shown elevated levels of D2 dopamine receptors, particularly in the striatum, even in people who haven't taken antipsychotic medication yet. One leading idea to explain this is the phasic tonic dopamine theory. It suggests that maybe the baseline, or tonic dopamine level, is low,
Okay.
which means there's less background inhibition. So when there is a dopamine release, a phasic release in response to stimuli, it's excessive. This hyperdopaminergic state is thought to underlie the positive symptoms.
That's a neat model. Now let's connect this biology to the real world. What environmental factors increase risk interacting with that genetic predisposition?
There are some really well-established ones. Urbanicity is a big one.
Living in cities.
Yes. More than 20 studies show a consistent link, roughly a twofold increased risk for people raised in urban versus rural settings. And the critical period seems to be the first 15 years of life, suggesting it's related to the developmental environment in denser areas.
That's fascinating. And migration.
Also a strong factor. Studies show increased risk for psychosis spectrum disorders among migrants, and interestingly, particularly in the second generation.
Second generation. So not the act of migrating itself necessarily.
It suggests that post-migration factors are really important. Things like social marginalization, discrimination, social disadvantage. These chronic social stressors seem to play a key role, fitting into a socio-developmental stress model.
And the substance use link, particularly cannabis.
That association is very consistent in the literature. Cannabis use is linked to about a 2- to 4-fold increased risk of developing a psychosis spectrum disorder, especially for heavier users. And importantly, longitudinal panel studies support the idea that cannabis use often precedes the psychosis, suggesting a causal contribution, not just self-medication.
Okay, shifting now towards treatment and outcomes. Before medication, the book stresses neurocognition. Why is that such a central issue?
Because these cognitive deficits, problems with memory, attention, processing speed, executive function, they have core features of the illness. They're often present early, even before the first psychotic break. And crucially, they are the single biggest predictor of real-world functional disability, more so than positive symptoms. Often, it impacts work, independent living, social relationships.
Can you give an example?
Yeah, the text mentions verbal list learning tasks. Someone with schizophrenia might recall, say, 5 out of 16 words on the first try, while a healthy control might recall 8 out of 16. That difference has huge implications for everyday functioning.
And current medications don't help much with cognition.
Unfortunately, not significantly. Existing antipsychotics, even the second-generation ones, offer minimal benefit for these core cognitive deficits. That's why cognitive remediation and psychosocial rehabilitation focused on cognitive skills are so important.
Right. Speaking of meds, let's talk pharmacotherapy. Chlorpromazine was the game changer, wasn't it?
Absolutely revolutionary. Its discovery in the early 1950s really marks the beginning of modern antipsychotic treatment. As a D2 antagonist, it worked well for positive symptoms and replaced older, much riskier treatments like insulin coma therapy. Today, we have first-generation FGAs and second-generation antipsychotics, SGAs. In general, they're considered similarly effective for positive symptoms overall.
So what's the main advantage of the SGAs, like clozapine or quetiapine?
Primarily, their lower tendency to cause extrapyramidal side effects, or EPS, things like stiffness, tremor, restlessness. This is often attributed to them having a lower maximum occupancy of D2 receptors compared to many FGAs.
And treatment isn't just one size fits all, right? It happens in phases.
Correct. There's the acute phase, focused on getting severe symptoms under control. Then the stabilization phase, to consolidate those gains and prevent early relapse risk, is high here. And finally, the maintenance phase, aimed at long-term relapse prevention and improving functioning. And a key point, people experiencing their first episode typically need lower doses than those with chronic illness. Also, managing adherence is critical.
Because people stop taking their meds.
Exactly. Non-adherence is a huge driver of relapse. That's where long-acting injectables, the LAIs, can be incredibly helpful. They provide consistent medication levels for weeks or months.
But meds alone aren't enough. Psychosocial support is vital, especially considering the old pessimism about outcomes. Tell us about the recovery movement.
Yeah, the recovery movement was so important. It really challenged that old Kraepelinian idea of inevitable decline. Modern outcome studies, longitudinal studies, have shown that recovery is possible, even probable for many. The text suggests about 2/3 of people can achieve reasonably full lives with the right support. And studies like RAISE demonstrated that comprehensive integrated treatment provided early makes a massive difference in long-term outcomes.
What kinds of psychosocial interventions have strong evidence?
Several stand out. IPS-supported employment individual placement and support helps people find and keep competitive jobs. Randomized trials show it results in employment rates 2 to 3 times higher than traditional vocational rehab.
That's impressive.
It really is. Then there's Housing First, providing immediate access to independent housing without preconditions like sobriety or treatment compliance. It's very effective for stable housing. And we can't forget peer support specialists, individuals with lived experience who serve as role models and provide unique support.
Okay. Finally, we need to address the stark reality of mortality and health disparities.
Yes, this is a critical issue. People with schizophrenia die, on average, 10 to 15 years earlier than the general population. The standardized mortality ratio is cited as 2.54, meaning they're over 2.5 times more likely to die at any given age.
And it's not primarily suicide.
While suicide risk is elevated, the leading cause of this premature mortality is now cardiovascular disease, heart attacks, strokes.
Why is that?
It's multifactorial. Metabolic syndrome, high blood pressure, high blood sugar, unhealthy cholesterol, abdominal obesity is very common. This is driven partly by lifestyle factors often seen in this population, like high rates of smoking and low physical activity. But it's also exacerbated by side effects of some antipsychotic medications, particularly clozapine and olanzapine, which carry the highest risk for weight gain and metabolic changes.
So the takeaway is a desperate need for integrated care.
Absolutely. Aggressive screening for cardiovascular risk factors, proactive management of metabolic issues, support for smoking cessation and healthy lifestyles. It all needs to be part of standard psychiatric care. We can't treat the mind while ignoring the body.
That wraps up our main dive. We've covered a lot. That huge shift in diagnosis from prognosis to dimensions, the vital role of negative symptoms, especially distinguishing primary versus secondary, and how genetics interacts with potent environmental factors like city living and migration stress.
And thinking about that biological underpinning leads nicely into our final provocative thought for you, the listener. The field is moving quite rapidly, actually, towards trying to define biologically based subtypes, sometimes called biotypes, using things like genetic markers, brain imaging, maybe inflammatory markers.
Moving beyond DSM categories?
Potentially. The idea is to stratify individuals based on their underlying neurobiology, perhaps using things like polygenic risk scores to guide more personalized treatments. So the big question this raises is, how will psychiatric classification evolve? How will science reconcile these emerging biological distinctions with the clinical symptom-based definitions we've relied on for so long, like those in the DSM? It's a fascinating tension to watch.
Definitely something to think about. This deep dive was based on excerpts from Kaplan and Sadock's comprehensive textbook of Psychiatry, 11th edition, Chapter 12. Thank you for joining us for this deep dive, and a warm thank you from the Last Minute Lecture team.